Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Updates on the Management of CDI, What's the Big Diff? Following the webinar, please be sure to follow the instructions alongside this webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free NC CE credit. Our speakers today are Dominique Smith, who is currently a PGY2 oncology resident with Novant Health Oncology Specialist in Winston-Salem. She received her Doctor of Pharmacy from Virginia Commonwealth University and completed her PGY1 training at Novant Health Forsyth Medical Center. Stephen Johnson is an assistant professor at Campbell University College of Pharmacy and Health Sciences. Dr. Johnson completed his postgraduate training in acute care at UCLA Medical Center and completed further training in internal medicine, infectious diseases, and academia at Duke University Medical Center and Campbell University. Dr. Johnson's practice site is at Novant Health Forsyth Medical Center, where he's an internal medicine infectious diseases clinical specialist. Dr. Johnson also practices in an infectious diseases clinic associated with Novant Health, where he manages primarily hepatitis C and HIV. Dr. Johnson's research interests include Clostridium difficile infection, risk prediction models for resistant bacteria, and hepatitis C. I will now turn it over to our first speaker, Dr. Smith.
Thank you, Amy, for that kind introduction. We are excited to share these guideline updates with all of you today. First, to review our objectives for the presentation today. First, we will discuss the epidemiology, presentation, and diagnosis of Clostridium difficile infection. Next, we will review new guideline recommendations and primary literature pertaining to the management of Clostridium difficile infection. Next, we will discuss strategies for prevention of healthcare facility onset Clostridium difficile infection, and last but not least, we will apply these new recommendations to patient cases. We wanted to start today's presentation with a patient case. Our patient is a 67-year-old female who presented with encephalopathy, dysuria, and mild flank pain for the past 4 days. His past medical history is significant for recurrent UTIs, a history of CDI in 2015 and 2017, for which he was prior treated with PO Metronidazole and PO Vancomycin. His vitals are listed here for your reference. Of note, he is febrile with a temperature of 101.8. His CBC and CMP are also listed here. Of note, he has a white blood cell count of 16.2, and his medications from home are listed for your reference. To follow his hospital stay, on day 1, a urinalysis was obtained and was consistent with the UTI. This was sent for a culture, and he was empirically started with ceftriaxone. On day 2, his urine culture showed a preliminary result of lactose-fermenting gram-negative rods, and his imaging was consistent with pyelonephritis. On day 3, the urine culture resulted as Klebsiella pneumoniae, and ceftriaxone was continued for his treatment. And then on day 5, the patient had new onset diarrhea, and a C. diff PCR was collected, and it returned positive. So what is Clostridium difficile? Clostridium difficile is a spore-forming gram-positive anaerobic bacillus. It's known to produce 2 exotoxins, toxin A and toxin B, and it is a common cause of antibiotic-associated diarrhea, accounting for 15 to 25% of all of these AAD cases. Diving into the epidemiology, the U.S. cases are approximately 500,000 cases per year, and it is associated with 15 to 30,000 U.S. deaths each year. Overall, the acute inpatient costs exceed $4.8 billion. These epidemiology statistics led to Clostridium difficile being classified as an emerging infectious disease by the CDC in 2012. Participation in this emerging infectious disease program addresses priorities for surveillance and applied research for these diseases. It aims to accommodate 4 goals, which are listed here on the slide. The first goal is to detect, promptly investigate, and monitor these pathogens and the diseases they cause. The second goal integrates laboratory science and epidemiology to optimize public health practice. The third goal enhances communication of public health information pertaining to these emerging diseases. And then goal 4 aims to take goals 1 through 3 to strengthen local, state, and federal public health infrastructures to support surveillance and implement prevention and control programs pertaining to these emerging infectious diseases. Looking more at the epidemiology, the patients that acquire C. diff are mostly female who are age 65 years old and who are Caucasian. However, do keep in mind that any patient of any age, sex, or race are at risk of acquiring C. diff. Additionally, we see about 64.7% of cases associated with healthcare onset or healthcare associated, and 37% are healthcare onset. Additionally, we see about 1/3 of cases occurring in the long-term care facilities, and 28% are seen within our communities. Recently, the epidemiology for C. diff infection has changed dramatically. We've recently seen an increase in the overall incidence, and the outbreaks that are associated with C. diff have been more severe. This is mostly attributed to the NAP1B1 027 strain of C. diff, which is transmitted more effectively than other strains. It possesses both the toxins for A and B, as well as the binary toxin, which is specific to this strain, and leads to an overall more severe disease presentation. Clostridium difficile cases are defined as the presence of diarrhea or the evidence of megacolon or severe ileus, in addition to either a positive laboratory diagnostic test or evidence of pseudomembranes on either endoscopy or histopathology. Additionally, cases will be specified to either be an incident case, a recurrent case, or a duplicate case. Incident cases are new primary episodes with new symptom onset and a positive assay result. These are in the setting of no prior positive result within the previous 8 weeks. Recurrent cases are episodes of C. diff with symptom onset and a positive assay results with a previous positive test within the last 2 to 8 weeks. And duplicate cases are defined as a positive stool sample where there was a previous positive stool sample in the last 2 weeks for the same patient. Additionally, C. diff is defined as where it occurred. So the first site where this infection can occur is a healthcare facility onset. These are events that are defined as being collected within the first 3 days or within greater than 3 days following admission to the facility. Additionally, C. diff can have community onset healthcare facility associated. So these are cases of CDI that occur within 28 days following discharge from a healthcare facility. All other cases are classified as community associated C. diff. For pathophysiology, C. diff is transmitted via 3 primary ways. The first is person to person, then surface to person, or fecal-oral route. Most C. diff is transmitted via either person to person or surface to person within our healthcare facilities. Following transmission, toxins create a dysbiosis of gut flora. These are primarily caused by either toxin A or toxin B. Toxin A is an enterotoxin that causes increased intestinal permeability and fluid secretion. Toxin B, which is the more potent of the 2 toxins, is a cytotoxin that leads to intense colonic inflammation. The toxins bind to target receptors within the gut. This causes endocytosis, translocation into the cell cytosol, inactivation of the Rho GTPases. It can cause changes in epithelial cellular structure, leads to apoptosis of the cells that line the colon, and causes a loss of intestinal barrier function. This leads to the leakage of fluid into the intestine and the entrance of granulocytes into the intestinal lumen, which causes the watery diarrhea and irritation within the colon. Some risk factors for Clostridium difficile infection include advanced age. As I mentioned earlier, most cases occur in patients who are aged 65 years or older. This can be due to their multiple comorbidities and increased risks of infection. Duration of hospitalization is another risk factor for C. diff infection. This puts patients at a higher risk of coming in contact with the C. diff within the hospital. Additionally, antibiotic exposure is a very well-known risk factor for C. diff infection. We aim to use less broad antibiotics as well as decrease the amount of time patients are exposed to these antibiotics to decrease their risk for C. diff infection. Chemotherapy is a new addition to the risk factors for Clostridium difficile infection. Many of our chemotherapeutic agents have antimicrobial properties, and therefore patients are at risk for the same reasons that they are following antibiotic exposure. And then additionally, these patients are usually immunocompromised due to prolonged periods of neutropenia. And our last risk factor listed here is GI surgery. So who should be tested for C. diff infection? Our target population are patients who have unexplained and new onset diarrhea, which is defined as greater than 3 unformed stools in the last 24 hours. When referencing the Bristol stool chart, we want to test patients who are having either type 6 or type 7 diarrhea. Looking at the new testing algorithm provided by the new guidelines, you'll see across the top that primarily we want to test patients for both the antigen and the toxin. So if patients test positive for both the antigen and the toxin, then it's determined that C. diff is present and you should initiate severity-based C. diff therapy. However, if either of these tests are negative, it does get a little bit more complicated. If both of the tests are negative, then it's determined that C. diff is not present, and you should evaluate your patient for other causes of diarrhea. If the antigen is positive, but the toxin is negative, then this should reflex to a PCR test. If the PCR test comes back positive, then C. diff might be present, and the patient should be looked at individually to consider other factors for their diarrhea and whether or not there's a high suspicion of C. diff infection for that patient. For antigen testing, this test detects the glutamate dehydrogenase from the C. diff bacteria. GDH is produced by both the toxigenic and non-toxigenic C. diff isolates, and it also cross-reacts with other anaerobes. Alone antigen testing is not a good indicator for potential expression of toxin and therefore should not be used due to the possibility that it could be inaccurate and misleading. Toxin testing is required for a laboratory diagnosis of C. diff infection. Toxin detection and neutralization by a cell culture cytotoxin assay is considered the gold standard with high sensitivity and specificity. However, this test is very costly and has a very slow turnaround time, which may be inconvenient in our healthcare environment. Enzyme immunoassays, or EIAs, are available for both toxin A and toxin B. However, compared to our gold standard, these have a lower sensitivity and specificity. Polymerase chain reactions, or PCRs, are also used for a quantitative detection of toxin genes. So what is the role of repeat testing in our patients? Per the new guidelines, it's not recommended to perform repeat testing within 7 days or during the same episode of diarrhea, and do not test stool from asymptomatic patients unless it's being used for an epidemiological study. So why should we only look at one specimen for 7 days? The graph that's depicted here shows the results of retesting patients who originally tested negative for C. diff. As you see, there was a low yield of a positive result, and only 1.1% of repeat tests performed in 7-day window yielded a positive result, including one false positive. So the findings from this study show that repeat testing for C. diff within 14 days of a negative result yields very little relevant clinical data. And all that we are doing is confirming the negative result of the initial test. Additionally, only 67% of patients with a previous positive result had a negative test for cure result following within 14 days of their original positive. So why can't you test for cure? One of the reasons is colonization. So up to 14% of elderly inpatients are colonized with or have C. diff on admission, and 6.6% of these patients are asymptomatic. Additionally, up to 56% have been shown to be colonized with C. diff from a previous C. diff infection. So what is the role of antibiotic stewardship in controlling our CDI rates? The first goal is to minimize the frequency and duration of high-risk antibiotic therapy, and the number of antibiotic agents prescribed will reduce C. diff risk. This can be obtained by implementing an antibiotic stewardship program, with considering restrictions specifically for the following antibiotics. Fluoroquinolones, clindamycin, and cephalosporins, specifically our third and fourth generation cephalosporins, have been shown to have a higher risk of C. diff. Additional factors that may be related to C. diff include proton pump inhibitors and probiotics. So proton pump inhibitors have been shown to have an epidemiologic association with C. diff. And of course, unnecessary PPIs should always be discontinued in our patients. However, there's been insufficient evidence to show that the discontinuation of PPIs result in preventing C. diff. Additionally, probiotics have insufficient data to recommend administration of these in the prevention of C. diff outside of a clinical trial. Next, looking at the new treatment recommendations. All of the new treatment recommendations will be coming from the clinical practice guidelines for Clostridium difficile infection in adults and children. This is the 2017 update by the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America. Comparing the guidelines from 2010 and the new ones from 2017, you will see that pediatric considerations have been added and the adult recommendations have been updated. There's the new testing methodology has been changed, as we have already went over earlier in the presentation, and now it is recommended that nucleic acid amplification test or a stepwise approach algorithm be used. Isolation for patients is recommended as a preemptive caution before results return and should be continued for at least 48 hours following the resolution of diarrhea. And additionally, antimicrobial stewardship is emphasized and recommends decreasing the use of broad-spectrum antibiotics. The next set of slides will be comparing the previous recommendations with the new recommendations, with the old recommendations being listed on the left and the new recommendations being listed on the right. So for the treatment of an initial episode for a patient that is classified as non-severe, this category was previously referred to as mild or moderate in the 2010 guidelines. The white blood cell count from the 2010 guidelines to the 2017 guidelines remains the same at less than 15,000 cells per milliliter. And the requirement for serum creatinine definition did change a little bit. Previously, it was defined as less than 1.5 times the pre-morbid level, and now it has a set level of less than 1.5 milligrams per deciliter. Additionally, the recommendations for medications have changed. In 2010, it was recommended to use metronidazole primarily for an initial episode of Clostridium difficile infection, but now there are more options with either PO vancomycin or Fidaxomicin taking the strong and high recommendations, with metronidazole only being considered if either vancomycin or Fidaxomicin are not available. Looking at treatment for an initial episode of severe diarrhea, this was previously called severe diarrhea as well in 2010. Our white blood cell count requirement is greater than or equal to 15,000 cells per milliliter, and here our serum creatinine requirement is a serum creatinine of greater than 1.5 milligrams per deciliter. Previously, PO Vanc was recommended, and this still holds a recommendation for the initial treatment of severe Clostridium difficile infection. However, now you can also consider using Fidaxomicin as well. For treatment of an initial episode of Clostridium difficile classified as Fulminant in 2010, this was referred to as severe and complicated. Requirements include hypotension or shock, ileus or megacolon, and the treatment recommendations are similar to those that we saw in 2010, with a recommendation for vancomycin 500 milligrams by mouth via NG tube 4 times a day, and you can consider adding a rectal instillation of vancomycin if an ileus is present, as well as adding IV metronidazole if an ileus is present along with the oral and/or rectal vancomycin. Next, looking at treatment for the first recurrence of C. diff infection, in 2010, they recommend using the same agent that was used in the initial episode. However, that has changed for the 2017 recommendations. If metronidazole was used for the initial episode, it's now recommended to use vancomycin 125 milligrams 4 times a day. And then if vancomycin was used for the initial episode, you can either choose to use a prolonged and tapered vancomycin regimen for the first recurrence, or you can use Fidaxomicin for the first recurrence. For second or subsequent recurrences of C. diff infection, in 2010, they only provided guidance for the second recurrence, and they recommended use of vancomycin in a tapered and/or pulsed regimen. In 2017, you can continue to use the vancomycin tapered and pulsed regimen, or you can use a combination regimen of vancomycin with rifaximin added on, or you can use Fidaxomicin, or you can consider a fecal microbiota transplant. Now I will hand it over to Dr. Johnson to talk to you a little bit more about the literature surrounding these new guidelines.
Okay, for the remainder of this presentation, we wanted to discuss the key changes in the guidelines by going through the literature that supports why these changes were made in the 2017 guideline updates. Also to discuss the newly added pediatric recommendations, to briefly introduce some of the clinical controversies, and to lastly go through our patient cases. Looking at this first slide here, which evaluates oral vancomycin versus metronidazole, when you look at this data, it becomes pretty clear why metronidazole was essentially removed from the guidelines, specifically talking about adult treatment. There were 2 main study endpoints that were evaluated here. The first endpoint looking at resolution of diarrhea at end of treatment. This is at the end of 10 days of treatment. The second endpoint was looking at resolution of diarrhea at end of treatment without CDI recurrence within 1 month of treatment. So looking at the first endpoint here, resolution of diarrhea at end of treatment, when looking at randomized controlled trials of those that were published since 2000, this included 687 subjects, including 3 different RCTs. The percent of resolution was 75% with metronidazole, whereas vancomycin was 85%. And this was a clinical significant difference with a p-value of 0.002 favoring oral vancomycin. When you look at all randomized controlled trials, this includes 5 RCTs, including 843 subjects. The results were similar to that data published since 2000, with 78% resolution in metronidazole, 87% resolution in those that received oral vancomycin. This was also a clinically significant difference with 0.008 for this included studies. When looking at resolution of diarrhea in a treatment without CDI recurrence approximately 1 month after treatment, when you looked at those same randomized controlled trials of those 843 subjects with 5 RCTs, the results showed that there was 63% in the metronidazole group, whereas there was 73% in the oral vancomycin group. This was also clinically significant, significantly different with a p-value of 0.003. Both study endpoints showing that oral vancomycin is superior to that of metronidazole. So this data makes it pretty clear why oral vancomycin is going to be preferred over metronidazole, and why metronidazole was again essentially removed from the guideline recommendations. So why in 2010 did the IDSA guidelines recommend metronidazole for mild to moderate disease? A lot of that was derived from this study here. This was published in CID in 2007. This was a prospective randomized double-blind placebo-controlled trial where there was 2 treatment arms, one receiving oral vancomycin, the other receiving metronidazole. And when you look at the results of this study, looking at overall rate of cure, the rate of cure was 84% with metronidazole, whereas vancomycin was 97%, showing that vancomycin was superior to that of metronidazole. However, that was looking at overall rate of cure. What this study also did was stratify subjects based upon disease severity, where there was a mild disease group and there was also a severe disease group. When looking at the mild disease group, there was no difference between treatment with those that received metronidazole or oral vancomycin with a p-value of 0.36. However, those that were in the severe disease group, metronidazole had a overall cure rate of 76%, whereas metronidazole had 97%, which showed favor towards oral vancomycin. So this highlights the fact, or highlights the reason why the 2010 guidelines recommended metronidazole for mild to moderate disease and oral vancomycin for more severe disease. However, since this publication in 2007, there's been several other publications, including this one here. This was a study that looked at 3 different treatment arms, including one treatment arm with telavimir. There was the other treatment arm was oral vancomycin, and then the last treatment arm was with metronidazole. When looking at the results of this study, the clinical success rate in telavimir was only 44%, reason why this drug is not used. Metronidazole was 72.7%, whereas vancomycin was 81.1%. And when you look at the statistical significance of that, that did have a p-value of 0.02, again favoring oral vancomycin. So it's pretty clear that oral vancomycin is a better drug over metronidazole, very clear that it's a more effective drug over telavimir. Again, the reason why the guidelines changed in 2017 to highlight that oral vancomycin is one of our preferred drugs to use. So what about Fidaxomicin? You may have heard some more recent information on Fidaxomicin. This is something that I get several questions from our providers about, and something that you may have seen some more information about. The 2017 guidelines highlight the role of Fidaxomicin. This was actually something that was completely missing in the 2010 guidelines. There was no mention of Fidaxomicin. This is primarily because, or essentially because, Fidaxomicin was not approved until June of 2011. And so when the guidelines were updated, then that's where they address Fidaxomicin and talk about its role in therapy. Fidaxomicin can be considered first line for the initial episode, and you also can consider it for recurrence as well too. So what is Fidaxomicin? It is a macrolide, just like azithromycin or erythromycin or clarithromycin. Its mechanism of action is the same. The unique thing about Fidaxomicin compared to other macrolides, though, is that it is minimally absorbed. It stays in the GI tract. One of the big downsides of Fidaxomicin, though, that you probably are aware of or heard about is its cost. So the AWP is roughly $4,400, which is one of the big disadvantages to Fidaxomicin. When you look at the data looks pretty good, though. When you look at oral vancomycin versus Fidaxomicin, these are the same study endpoints that were evaluated when looking at oral vancomycin versus metronidazole. So for the first endpoint here, looking at resolution of diarrhea at end of treatment. So this is 10 days of treatment. This is pooled data from 2 randomized controlled trials, including roughly 1,100 subjects. The percent resolution was the same, 88% with Fidaxomicin, 86% with oral vancomycin, and no statistical difference there with the p-value of 0.36. However, when you look at recurrence, this is where Fidaxomicin has a clear benefit. So this is resolution of diarrhea into treatment without any CDI recurrence 1 month after treatment. Those same pooled randomized controlled trials, 71% for Fidaxomicin and 57% for oral vancomycin, with the p-value less than 0.001, indicating that there is less recurrence with Fidaxomicin when compared to oral vancomycin. So this is the clear benefit of Fidaxomicin. When you look at the data a little more closely, so this first study, it was a prospective, multi-center, double-blind, randomized parallel group trial. It had the 2 treatment arms, one Fidaxomicin, the other oral vancomycin. When you look at the results of this study, for clinical cures, they're roughly the same. There was no statistical difference between the two, Fidaxomicin 88.2%, Vancomycin 85.8%. However, when you look at recurrence, then that's where there's the clear benefit with Fidaxomicin. So 15.4% had recurrence with Fidaxomicin, whereas Vancomycin had 25.3%. When looking at, this was a composite endpoint of global cure taken in consideration, clinical cure and recurrence, 74% for Fidaxomicin and 64% for Vancomycin, in favor, again, of Fidaxomicin. So the conclusion of the study is that Fidaxomicin is non-inferior to Vanco as far as clinical cure, however, is associated with significantly lower rates of recurrence compared to oral Vancomycin. Next study, very similar, another multi-center, double-blind randomized, this was a non-inferiority trial as well, that looked at two treatment arms, one with Fidaxomicin, the other with oral Vancomycin, and looked at similar results with clinical cure and recurrence. And this study found very similar results where the clinical cure was essentially the same, 88% with Fidaxomicin, 87% with Vancomycin, with no statistical difference. However, again, with recurrence, far less with Fidaxomicin when compared to Vancomycin. So roughly 13% Fidaxomicin and 27% with Vancomycin, with a p-value of 0.0002. And looking at sustained response, so this was looking at individuals that continued to not have recurrence, 76.6% for Fidaxomicin and 63.4% Vancomycin. That was also statistically significant. So pretty clear that Fidaxomicin has less recurrence. So the question comes up a lot, why does Fidaxomicin have less occurrence associated with that? It's thought that that's related to the fact that Fidaxomicin is less likely to alter the normal gut flora, whereas our typical treatment that we used to use with oral Vancomycin and Metronidazole are more likely to alter your normal GI flora. But what about fecal microbiota transplant, or FMTs? This is something that our institution is doing more and more of. There's more literature coming out about FMTs. FMTs have been around for a while. However, the data is getting more and more robust for using it. This slide here just includes some of the key points about FMTs to keep in mind when they're performed. The first thing to keep in mind with the FMT is that you should discontinue any anti-CDI antibiotics 48 hours prior to that FMT. And this is because of the fact, again, that our agents to treat C. diff can actually alter our gut flora. Specifically, Metronidazole and Vancomycin are more likely to have that associated with it. So you need to make sure that you discontinue that treatment prior to the FMT being performed. FMTs can be performed by two routes. Can be performed by an upper GI route or a lower GI route. If it's performed by an upper GI route, you just need to make sure that they get a proton pump inhibitor, and they should get that 48 hours prior to the FMT. A standard large volume bowel preparation for both upper and lower GI delivery should be done. The other thing too with FMTs is that the donated stool is going to be frozen. And so prior to the FMT being performed, that donated stool should be thawed 1 to 4 hours prior to the procedure. The other thing that you may have recently seen some literature on is FMT oral capsules. There was a recent publication that compared FMT oral capsules to doing traditional FMT by endoscopy or colonoscopy, and found that the oral capsules were non-inferior to the traditional routes of FMT. So this is something that we'll probably see some more literature on in the near future, and something that may be done more often. But if you're using the FMT oral capsules, they should be kept frozen until immediately prior to their administration. The other important thing to keep in mind is related to this picture here on the right, is that it's very unlikely that an individual would acquire an infectious disease from an FMT, that the donor themselves and the donated stool are rigorously screened for any possible infectious diseases. And so the likelihood that an individual would acquire an infectious disease from an FMT would be very unlikely. When you look at the data that compares oral vancomycin versus FMT, this is also very clear that FMT is actually going to be the more effective treatment. The study endpoint for this study This was just one study with only 29 subjects. However, what they were looking at is the resolution of diarrhea at the end of treatment without any CDI recurrence. And their CDI recurrence, they extended it out beyond 1 month. They looked at out to 56 days after treatment. And what they found as far as the percent resolution, it was 81% with FMT, whereas oral vancomycin was only 31%. And this was a statistical difference between the two, favoring FMT, looking a lot better than oral vancomycin. When you look at this data a little bit closer, this was an open label randomized control trial where they had 3 different treatment arms. The first treatment arm was individuals receiving high dose vancomycin at 500 milligrams 4 times a day, and they got that for 4 or 5 days, followed by a bowel lavage, and then they also got an FMT. Treatment arm number 2 was high dose vancomycin at the 500 milligrams, plus they got the bowel lavage. And then treatment arm number 3 was just high dose vancomycin for 14 days. When you look at the results from this study, looking at group 1, so these are the individuals that had FMT performed. The first column there is group 1 with 1 infusion. So these are individuals that received only 1 FMT. So after 1 FMT, the resolution was 81.3%. That group 1 overall, that was individuals that did not have resolution of diarrhea after the first FMT, actually had a subsequent FMT from a different donor. And after that subsequent FMT, roughly 94% had resolution. When you look at group 2 and group 3, much lower resolution rates at 30.8% and 23%, all favoring FMT to be the more effective treatment option. That was statistically significant when you look at all the different p-values comparing group 1 to group 2 and group 1 versus group 3. So next, changing gears and getting into one of the other big updates in the guidelines is addressing pediatric issues. And first here, we're going to talk about some of the big changes that they added here, talking about pediatric testing and things to keep in mind for pediatric testing. In summary here, the big take-homes from this slide is that neonates and infants and toddlers should not be routinely screened or tested for C. difficile infection. It'd be highly unlikely that these individuals would actually acquire C. difficile infection. So you think about other potential causes of diarrhea. However, children who are 2 years or older, then that's where you can actually consider doing C. difficile infection testing, especially in the setting of high risk factors or relevant exposures, or in individuals that had prolonged or worsening diarrhea. When you look at the other big part of the pediatric recommendations, this focuses on treatment. This table here summarizes the treatment recommendations. And this table probably looks familiar to a lot of you if you're familiar with the 2010 adult treatment recommendations. These recommendations are almost identical to that. When you look at the initial episode, so these are in non-severe, this is similar to the 2010 recommendations for mild or moderate disease. They say that you can use metronidazole or vancomycin in the 2017 update for pediatrics. When you look at individuals with more severe disease, that's where they say vancomycin has the clear benefit, and you can consider adding metronidazole to that oral vancomycin. Just to take a look at that in a different view, to summarize that table, for initial episode and for those that have a first recurrence, these would be for non-severe individuals. The pediatric recommendations could be metronidazole or vancomycin. So this is the one place where metronidazole remains in the new guidelines is for pediatric use. For initial episode, if it's severe, this is where vancomycin has the clear benefit and should be used over metronidazole. And for second recurrence or more, that's where we can consider vancomycin or an FMT can be considered for multiple recurrences. So if we look at our 3 main treatment options here with vancomycin, fidaxomicin, and metronidazole, this excludes FMT, but if we look at our main 3 oral options here, it's pretty clear the big downside to fidaxomicin, again, is going to be the price. Fidaxomicin is the most expensive option listed here. Vancomycin can be expensive. This is speaking of the commercially available capsules. However, most institutions, including our own, take the IV product and compound it into the oral solution, which is really cheap. As far as initial treatment response, pretty clear based on the data that vancomycin and fidaxomicin are superior drugs over metronidazole and are a lot more effective at managing CDI. And when you look at recurrence, that's where the clear advantage is with fidaxomicin being much less likely to be associated with recurrent CDI compared to vanco and metronidazole. So what about some other options? The guidelines mention a few other potential options. So we have some agents that are probably effective, and then we have agents where there's just not enough data to support their use. Some probable effective agents would be nitazoxanide. Nitazoxanide, when you look at the data, looks pretty similar to oral vancomycin. It is relatively expensive. Its initial treatment response looks good, and it also is associated with recurrence, just like oral vancomycin is as well. The reason why this is not considered a first-line agent is there's not as much data as there is with our other first-line agents. And so right now, this is just considered a probably effective option that you can consider. Fusidic acid is not available here in the US. As far as inadequate data to support their efficacy, that would include things like rifaximin, tigecycline, and bacitracin, just not enough data to support their routine use. So despite the 2017 guideline update, the guidelines did address a lot of our unanswered questions from the 2010 guidelines. But despite this update, there still remains some clinical controversies and still some questions that have not been answered quite fully yet. These clinical controversies really can be divided into two groups. One thinking about prevention, the other one speaking about treatment. In regards to prevention, there's still some controversy as far as risk identification, as far as what is the best way to identify those that are at high risk for C. difficile infection. Ideally, if we can identify those that are high risk, we can somehow prevent them from acquiring C. difficile infection. There's been a lot of publications that looked at various risk factors. Several publications have identified differing risk factors. Some identifying certain things as risk factors and others not identifying that same variable as a risk factor. So there is some differences there. And so as far as the best way to identify high risk, that still is unknown. Also, the potential role of probiotics is unknown as well. Should these be used for primary prevention or should they be used for secondary prevention? It's really not known. The data is inconsistent, with some data showing that it supports their use, some data showing that it does not support. And so the role of probiotics is still somewhat unknown. Other preventive strategies is more controversial. There are other things that have been utilized to try to prevent C. difficile infection, including oral vancomycin prophylaxis for both primary and secondary prophylaxis, using fidaxomicin for prophylaxis. There's very limited data evaluating both oral vancomycin and fidaxomicin, so at this time should not be used routinely. The IDSA 2017 guidelines do make a mention about oral vancomycin for perhaps considering that for secondary prophylaxis, but again, very limited data to support that recommendation. When speaking about treatment, one of the big controversies is the cost effectiveness of fidaxomicin. As I've alluded to already, fidaxomicin is a very expensive treatment. So should we be using fidaxomicin first line, or should we start a patient on oral vancomycin? If they fail vancomycin, then switch more to fidaxomicin. Also, looking at early FMTs, should we do FMTs before we start someone on, say, vancomycin or fidaxomicin and use that as initial treatment, or should we wait for individuals to have multiple recurrence? So that's still a debated topic. And the last one mentioned here is using high-dose oral vancomycin. We know that higher doses of vancomycin are more likely to alter your gut flora, perhaps increase the risk for VRE colonization. And so using that higher dose is somewhat controversial, and perhaps we should just be using the 125 milligram dose and not go up to high dose vancomycin. So going back to our cases that we presented earlier, back to patient case 1. So again, this was the 67-year-old male who presented with encephalopathy, dysuria, mild flank pain for the past 4 days. The past medical history is significant for recurrent UTIs. They had a history of C. difficile in 2015 and 2017 and treated prior on oral metronidazole, then oral vancomycin. They do have a fever of 101.8. The BP is normal, heart rate at 89, respiratory rate at 16. White count is 16.2, and all their other labs are within normal limits. Their home meds are lisinopril, levothyroxine, metoprolol, sertraline, multivitamin, and omeprazole. So our question related to this case is based on this information provided, how should this patient's C. difficile infection be treated? And I'll give you a few seconds to think about that. Okay, so this one would be an FMT. So given that they've had multiple recurrences in the new update, they mentioned multiple recurrences, those individuals should get an FMT. Looking at patient case number 2, so this is a 67-year-old male who presented to the ED complaining of persistent watery diarrhea for the past 2 days. A stool sample is sent for a C. difficile PCR, which returns positive. He is hemodynamically stable and no signs of ileus. Based on the information provided above, how would this patient's C. difficile infection be classified? So again, I'll give you a minute or two to think about that. Okay, so like mentioned earlier, the 2 big key things we're looking at here to help us classify the severity would be the serum creatinine and the white blood cell count. This individual's white blood cell count is well above 15 at 22.3. So this individual would actually be classified as severe, and our preferred treatment now is going to be the vancomycin, the 125, 4 times a day for 10 days. For case number 3, this is a 45-year-old female who presents to the ED complaining of persistent watery diarrhea for the past 24 hours. A stool sample is sent and C. diff PCR returns positive. She is hemodynamically stable and no signs of ileus. Upon review of her chart, you see that she was admitted approximately 3 weeks ago with C. diff and was treated with metronidazole. So based on this information provided above, how would you prefer to treat this patient? Okay, so again, looking at the serum creatinine and the white counts, in this case, not above our threshold to classify this as severe, so this would be a non-severe. And still, our preferred treatment for non-severe is going to be oral vancomycin at the 125, 4 times a day for 10 days. Getting to our last case, and probably the more difficult case, this is a 66-year-old female presenting to the ED complaining of persistent watery diarrhea and severe abdominal pain. The patient only has one small stool in the ED, which is sent to the lab and see if PCR returns positive. Upon presentation, the patient is hemodynamically stable. However, now her blood pressure is 78/40. Following stabilization of BP, a CT of the abdomen and pelvis shows concern for an ileus. So based on this information provided above, which agent or agents would be preferred for the treatment in this patient? Okay, so this patient would be considered to have a fulminant C. difficile infection. So the guidelines actually recommend that they should receive all these treatments, where they should get metronidazole IV, the high dose oral vancomycin, and then actually the rectal instillation of vancomycin. You could even say that you can add on IV vancomycin since they are septic as well too. So in this case, you can say all the above. The conclusion of this presentation, we just wanted to highlight the fact that CDI is an emerging infectious disease that is associated with a significant burden on our healthcare system. That there are some significant changes that were added to the updated treatment guidelines, including how we should test more appropriately, addressing the issue with metronidazole being an inferior drug, and highlighting the fact that it's no longer recommended as a first-line therapy in adults. Also highlighting the fact that Fidaxomicin was added as a treatment option. And despite its improvement in treatment and perhaps prevention, that we really still should be focusing on antimicrobial stewardship efforts, and those really should be emphasized in each institution. However, despite all these changes, that there are still a few clinical controversies that still remain. So in conclusion, we have enjoyed providing this webinar for NCAP. We hope that you found the content to be informative. To receive continuing education, please follow the instructions provided for this webinar on the NCAP website. And we thank you for your participation.